Cipro is like candy in medicine, okay? I mean, people take it all the time. MG patients have crises all the time. It's hard to know that those are connected, okay, because they happen to very often. It took some time for us to figure that out, okay? And in fact, if you look at the list of medicines that make MG worse, I don't know, you guys have probably all seen it. It's about 2 long columns long, okay? As far as I'm concerned, most of those I've never seen. I'm actually not sure I believe it, okay? But a handful of them are true, and one of them is going to be Cipro. Evidence-based medicine thing, you guys kind of know what we're talking about here. Over the past few years, it's kind of emerged in medicine that a lot of the treatments, a lot of the things that we're doing, especially things that we're doing that cost money, okay, have never really been proved to work. And so we're moving back now and reviewing a lot of those things, and we'd like to see that there's evidence behind our use of these treatments, or however, they're usually treatments. And so that's where the term evidence-based medicine came from, okay. Imuran is a medication that, again, I don't know that there's been a double-blind controlled trial or a randomized controlled trial to prove that it works. We do know that it tends to affect the white blood cells that we think make the abnormal antibody, and that's why it was used, or why it was begun to be used. Secondly, most patients can't be treated for their myasthenia with Imuran alone. It's usually used in combination of prednisone, and it's the ability to get the prednisone dose lower. It's what's called a steroid-sparing agent. That's how we mostly refer to it and use it, is to be able to get your prednisone dose down so you have less chance of side effects. So again, in your particular case, it'd be awful hard for me to say. It often takes, after you start Imuran, it takes sometimes months for it to start working. I mean, you got to be real patient with Imuran. Okay, with the generic is azathioprine, I'm not sure, okay? And so that's why we don't like to, we like to think hard before we stop it, because we have to restart it. It's day one, 6 months or longer before it can start working again.
So methotrexate, you don't supplement prednisone with it?
Again,
Yes.
It all depends. Most patients are on prednisone besides, okay? We don't like to, if you're on prednisone, it may be doing not perfect, okay? We don't like to stop it and then start the methotrexate, okay? We like to keep you here and slowly build this up, because this takes a while to kick in, maybe a few weeks, okay? And then see, after you're stable for a while, then maybe see if you can get away with a little bit, slowly taper the prednisone. The reasons to slowly taper prednisone, if you're on a very high dosage, there's more than one reason. One reason is that patients simply do better, okay? We're more likely to get you down or off of it if we go slowly. But the other reason is to find the floor, okay? That is, if you're on 40 a day, maybe you go down to 35, okay? Then maybe you go down to 30. Then we actually maybe go by 2 milligrams at a time instead of, the lower you get, the slower we go, okay? So we can get you down to 28, maybe 25, you're doing okay. At 22 you don't. Then we know that 25 is the floor, okay? So that's another reason to do that, to go slowly. Is because, whatever medication or treatment you offer myasthenia is for most patients a lifelong disease, okay, at least years. So all these medications you're going to be on for years, let's find the lowest dose that's effective. Okay, it's worth taking the time to do that, I think, for the most part. After about 2 months, it will start that osteoporosis-like thing. So a lot of times we try to keep you on calcium and vitamin D and, whatever else that the endocrinologist, if we need it, or whoever your internist thinks that you should have. I mean, basically, as a neurologist, it's kind of nice that I give you the medication and make somebody else fix the problems that I cause. Okay, it's kind of nice that way. Okay, okay. So, but again, it's nice to be a team though that's looking in on those things to reduce the chance of that happening. Okay, we can never eliminate it, unfortunately, unless we took you off prednisone. That's why we're looking for new treatments to get you off that stuff. Okay.
What are some of the signs that, as a support person, I can be watching for when he's reducing the prednisone? Because that's what they're doing each month. So what are some signs that I can say, maybe we need to go back up?
Well, it would be usually what had been bugging you before you started it.
Okay.
Okay. I mean, if you're having speech troubles, it's likely to be that. If you're having double vision, that's likely to come back.
Okay.
Okay. It may just be more fatigue. Okay, because fatigue is the most common symptom of myasthenia. Okay, looking back. Okay.
I just.
As a
maybe
general
I'm
rule,
trying-
the effects of steroids aren't so touchy that you have to worry about what time of the day you do it. It just doesn't.
Okay, thank you.
As a general rule, the recommendations are to give the steroids in the morning as a single dose. Most of you are probably taking it that way. The reasons are twofold, okay? One is that we all make steroids. All of our adrenal glands make steroids, okay? And we know that that's when it's the highest level in our blood is in the morning. So it kind of mimics physiologic steroid circulating in your blood, okay? The other one is that many people, it makes them a little high. Gives them a little juice. They even have trouble sleeping, so that's why we give it to you in the morning, so you yell at us less. Okay? Does everybody pretty much know what that is, what they mean by musk myasthenia? Okay. Myasthenia gravis, or what, I don't want to call it classical myasthenia. I'm not saying that you're not classical, Mary, or something like that, okay? But we were able to actually measure the antibody, the abnormal circulating antibody in myasthenia that blocks that neuromuscular transmission thing. And that is the acetylcholine receptor antibody. Okay, that's what everybody, when you come in with myasthenia, that's what the blood they draw for. Okay, and they sent it, used to have to send it to Mayo and Denver, okay, and now all kinds of labs do it. Okay? Now, we've also known for a long period of time that only 85, pushing 90% of patients with myasthenia have a measurable acetylcholine receptor antibody. Okay, so they're antibody negative, what we call seronegative. Okay, you have to always have to have a fancy name for stuff. Okay, so that was a seronegative person that we wouldn't be able to measure the antibody. So we just assume that there's some technical reason we're not measuring the antibody. Okay, either you're not making enough, okay, or you're making just enough to get to all the acetylcholine receptors and the muscles in your body so that it's not circulating around or something. Okay, but now we found that about 2/3 of those patients that were seronegative now have a different antibody called MuSK. Okay, MuSK stands for muscle-specific kinase. Okay, so we always have to make an acronym for things in medicine. Okay, so what that is that, you know, if you have the muscle cell and you have the acetylcholine receptor here, okay, right next to it is the MuSK protein sitting on the cell wall of the muscle, okay? And so we think that somehow the antibody there makes it so the acetylcholine receptor doesn't work. So it's another autoimmune disorder, very, very similar to actual myasthenia, appears to respond to the same treatments, although not quite as well statistically if you look at them as a group, okay? And in fact, IVIG doesn't seem to work nearly as well as plasma exchange for some reason. When in myasthenia gravis that are acetylcholine receptor antibody positive, they seem to work about equally. Okay. So, again, this is a little bit of a different disorder. It is a myasthenic disorder. That is a neuromuscular junction disorder. It's on the muscle side. Okay, so again, we treat it as if it's like myasthenia, but we're kind of scratching our heads that there may be some more specific treatments for that work a little differently than myasthenia does. We do know that, first of all, immune systems are highly genetic, highly hereditary. Okay, so the assumption is that the reason that someone gets myasthenia is at least in part due to the kind of immune system you have. Okay, again, we don't know why, though, it triggers that. We also know that there's about a 10 to 12 times increased risk of having myasthenia if you have a first-degree relative that has myasthenia, that is, a sibling or a parent with myasthenia. Okay, so it's assumed that that's the reason, it's because that immune system is highly hereditary. Okay, but still, you know, we're talking about 5 per, 100,000, 8 per 100,000, 10 times that's still only 80 per 100,000. It's still not a very big number. Okay. So even if you have a first-degree relative with MG and it increases your risk by 10, it's a pretty low risk. Okay, when you look at the absolute numbers.